Thank you very much. First of all, let me apologize for the delay. It's beyond my control. There's some technical issue. It gives me a great pleasure on behalf of Oman Heart Association and National Heart Center to welcome you on this 7th Cath Lab Day. As you can see that this Cath Lab Day today is a bit different. It is the first virtual meeting. We used to meet face-to-face, but now the situation of the pandemic, we cannot do that at a large gathering. So it's unique in that sense. It's also unique in its program and its participation. I understand that this is probably the first time we have participants from outside Oman. And the program, you can see, is very rich, and it has got a lot of eminent speakers from doctors, nurses, technologists, and people who are involved in Cath Lab. Let me just say a few words about the Cath Lab story. And I think it's in this particular occasion, I must mention something that happened last week. We lost last week, but what we call the father of the Cath Lab in Oman, Dr. Rashid Shagabani. Dr. Rashid started the Cath Lab service in Oman in 1987 as the first person doing cath. And then we joined him slowly from 1990, myself, Abdullah, 1991, 92, and then Dr. Mukheni, and then the number started to increase, and mashallah, now we can see good number of doctors, young doctors, taking the responsibility. We started at that time probably with 1 or 2 technologists and a few nurses. We had radiographers because we had to use the old film, that film that after every cath lab, we used to go to the dark room, take about 20 minutes, half an hour, to bring us that film, which we have to run on a machine and see the cath. The maximum number we were doing at that, initially we were doing only 2 days a week. And the maximum number is about 5 diagnostic caths per day. That used to take the full day from us because we are slow, because we take the time for the film to be developed. Then things progressed in the 90s, started angioplasties in 1970s, 1997, other interventions, mitral and so on, electrophysiology service. And then progress so fast, pediatric cardiology and so on. And now you can see, and not here to present the data of the Cath Lab, probably somebody else would mention that we are doing thousands of cases, not in number, but there is a high quality service going on with a large number of doctors, technologists, nurses. Many of them are local, and they're actually doing a great job, not at the level of Oman, but I say at the level of the region. It's well known today that the National Heart Center and the Cath Lab in it is a well-known place in the whole region. And I think this is not possible without the effort of everybody working in that place. I don't say X person, but it is a joint effort from everybody working in the Cath Lab, support from the administration, National Heart Center, Royal Hospital, Ministry of Health, and the main issue is actually the dedication of the people in the Cath Lab. I think you will really, we will all benefit from these 2 days program, which I saw it's a very rich program. Unfortunately, I may not be able to attend the whole program for the 2 days, but I try to attend as much as possible from it. And I wish you a very successful meeting. And since I joined late, I don't want to delay more. And I wish you a very successful meeting and leave you with the program to start. Thank you very much.
Thank you so much, Dr. Kadhim Jafar Suleiman, the president of Oman Heart Association. I think we should start now our meeting. We will start with Dr. Khalid Al-Saidi. Dr. Khalid Al-Saidi, he's a consultant cardiologist in National Heart Center. He graduated from Sultan Qaboos University. He did internal medicine residency training at OMSB and fellowships in cardiology and interventional cardiology at University of Nebraska Medical Center. That's in USA. He is currently working as a consultant interventional cardiologist at the National Heart Center. Dr. Khalid, can you share your screen?
Sure. Do you see the screen now? Are you seeing the screen? Sorry.
Yes, Dr. Khalid, we can see it.
Okay, good. So my topic is about coronary artery disease in the COVID era. Okay, so this is the outline of my talk. So I will be speaking about COVID-19, epidemiology and pathophysiology, cardiac manifestations of COVID-19, impact of COVID-19 on cardiovascular surfaces, management of coronary artery disease in the COVID era. And finally, I'm going to talk about NACME, which is the outcomes. We'll talk about the outcomes from this North American COVID-19 STEMI registry. So we'll start with the first topic, epidemiology and pathophysiology. Of course, you know the number of cases is the pandemic is still raging, and this is captured from a few days ago. I am sure by now this numbers are going even more. We have more than 80 million cases worldwide, and 128,000 locally death, 1,500 locally here in Oman, and 1.76 million worldwide. The frequency of myocardial injury among hospitalized patients with COVID-19 ranging from 7 to 28%, depending on how sick the patients that you are looking for. So if you are looking for an ICU patient, it will be probably upward of 28%. If you are looking for all admissions, then maybe around 7%. The prevalence of coronary artery disease among patients diagnosed with COVID-19, again, ranging from 4.2% to 25%. And this is basically depending on the population you are looking at. In the US, it was reported as 9%, which is basically similar to the prevalence of CAD in the general population. So it seems that CAD patients, they have the same chance of getting the virus as anyone else. They don't have increased risk of getting the virus, but once they have the infection, then their risk of complication is much, much more higher than the general population. And we are going to talk about that. So this is the virus we are talking about, severe acute respiratory syndrome, coronavirus 2. It's a single-stranded positive sense RNA virus. So basically, this is nothing but like a messenger RNA. The genome of this virus is messenger RNA that can be directly translated into protein inside the cell. And of course, it causes COVID-19, which we know now is everywhere. This is the replication cycle of SARS coronavirus 2. And if you see here, the virus basically gain entry to the cell through the ACE2 receptor. Why I'm mentioning this, because ACE2 receptor is not only available in pneumocytes or in the lungs, but it's also very abundant in the heart muscle and the blood vessels. So this is maybe one of the mechanisms or one of the supposed mechanisms by which the virus may affect the heart. And then of course inside, so it enters the cells by this endocytosis, and then it uses the cellular machinery system to replicate itself. So its genome get translated into the 4 proteins that eventually will be assembled and will come out from the cell. So every infected cell will produce hundreds of virions, which will continue to infect other cells. We know that COVID-19 has 3 distinct stages. Stage 1, which is the early infection. Basically, this is the viral stage. The only thing abnormal here in labs is the reduced lymphocyte count. Otherwise, the patient is having upper respiratory tract infection symptoms, maybe fever. 80% of patients will never go beyond this. Luckily, the disease will stop at this stage. However, 20% of patients will progress to stage 2, which is the pulmonary phase, during which you will see the classical pneumonia, abnormal chest imaging, and so on. And then about 5% of patients will progress to stage 3, which is the hyperinflammation or exaggerated host response. During this stage, you will see elevated inflammatory markers, cytokine storms, and multi-system involvement, including the heart, with elevation of cardiac biomarkers. And this happened about 7 to 8 days after the onset of symptoms. We'll talk about cardiac manifestations of COVID-19. And before that, I want to explain a few of the terminology I'm going to use today, because I know that some of you probably not familiar with those terms. I know most of you are nurses and technicians, so better to explain this. Acute myocardial injury, myocardial infarction type 1, otherwise known as acute coronary syndrome, and myocardial infarction type 2. So the acute myocardial injury, so basically myocardial injury is any elevation of cardiac troponin above the 99th percentile, upper reference limit. Now, this can be of 2 types, either acute, if there is a rise and fall of cardiac troponin values, so basically it's trending, then that's acute myocardial injury. And then chronic, if it is static elevation of cardiac troponin, basically there is less than 20% variation. You see this very commonly in patients with renal failure. You see this in patients with heart failure also, where the troponin is chronically elevated, but is not changing over time. It's not trending. And then myocardial infarction, of course, infarction is nothing but a specific type of acute myocardial injury that is due to ischemia. So if you have acute myocardial injury, that is elevation in troponin, plus you have evidence of myocardial ischemia, then this is MI. Evidence of ischemia is you need symptoms. You need one of those things, either symptoms, angina or angina equivalent, new ischemic ECG changes, whether it's ST elevation, ST depression, development of pathological Q waves, or imaging evidence of new loss of viable myocardium or new regional wall motion abnormalities in a pattern consistent with an ischemic etiology. This MI can be further classified into type 1 or type 2. So type 1 is caused by atherothrombotic coronary artery disease and usually precipitated by atherosclerotic plaque disruption, i.e. rupture or erosion or calcified nodules. Type 2 is caused by oxygen supply and demand mismatch. Now, those can be differentiated clinically by the context of the presentation and by the mechanisms involved. So you look for how the patient is presented, and you look for any mechanisms for oxygen supply demand mismatch, things like tachycardia, hypotension, hypoxia, and so on. The definitive proof actually is by identification of a coronary thrombus by angio, including imaging, or on autopsy. So this diagram shows you the various manifestation of COVID-19 in the heart. So you see here, this is the cytochrome or hyperinflammatory state leading to non-specific or non-ischemic myocardial injury. Probably this is the most common pathway by which the COVID-19 affect the heart. And then you look here and you see there is the oxygen supply-demand mismatch. That's the type 2 MI, either because of hypotension, increased metabolic demands, hypoxia. All those create this imbalance leading to troponin rise. Then there is this entity that we are very concerned also about, which is the plaque rupture. We know that plaque rupture can happen more frequently during this hyperinflammatory state, so predisposing patient to getting acute coronary syndromes. Of course, this requires specific treatment. This is why we have to differentiate type 2 from type 1 myocardial infarction. Then we have a lot of other mechanisms. So one of them is the direct viral invasion of the myocardium. Not really 100% proven, but we have a lot of evidence to support this theory. I don't think this is the commonest way by which the virus affects the heart, but this is the myocarditis. So when we say myocarditis, it's basically direct invasion of the myocardium by the virus. Now we have also microthrombi, DIC, and so on. This is common with COVID-19. We have vasculitis, endotheliitis with vascular injury leading to microvascular dysfunction, and we can see the manifestation of that in the heart. Stress cardiomyopathy is also another very important mechanism by which the virus affects the heart. So it's usually a combination of ischemic, non-ischemic myocardial injury that also interplay with comorbidities. As you can see here, the age, the hypertension, diabetes, presence of coronary artery disease, heart failure, AFib, and also stroke or cerebrovascular disease. All of this lead eventually to the cardiac manifestation of heart failure, cardiogenic shock, myocarditis, arrhythmias, ACS, cardiomyopathies, and so on. If you see here, this is the influence of comorbidities on case fatality rate. So if you see the odds ratio for diabetes is 9, much more than the influenza. You see the influenza is like 0.6. This is the common influenza. Hypertension is 7.4. Cardiovascular disease is 13.6, the odds ratio for fatality. And this is much, much higher than the influenza, the usual influenza. Here, this is a chart. This is from data from China. You see here, this is the mortality basically. So mortality of patient with prior cardiovascular disease and elevated troponin is very, very high, approaching 70%. Mortality of patient without cardiovascular disease but elevated troponin is almost 40%. While if you don't have elevation in troponin with prior CAD, then the risk is about 13%. And if you don't have any of the two, then the risk of death is like 7%. So there is a huge difference according to presence of cardiovascular diseases and troponin elevation. You see here, this is the mortality according to the level of troponin. As you can see, if you have a very high troponin, mortality is approaching 91%. Troponin is undetected, mortality is 1%. So a huge difference. So in essence, troponin is a very powerful predictor of mortality. Now, the issue is, it's not the troponin that is killing the patient. Troponin is just like a marker of severity of the underlying COVID-19 infection. You see here those charts of various laboratory investigations, and you can see here the troponin down here, but you see also the red line is the non-survivor, the blue line is the survivor. So you see in survivors, there is no elevation, but in those patients who didn't survive, there is significant elevation of troponin. But at the same time, you see other things like interleukin-6, which is a marker of cytokine storm. You see the D-dimer elevation, the ferritin, LDH. So this is part of a syndrome. It's not just is not just the troponin. Anyway, now we'll move to talk about the impact of COVID-19 on cardiovascular surfaces. So we know about this phenomena of decline in hospitalization rate by about 40 to 50% during the pandemic. Now, we don't know the exact explanation, but probably it's a combination of multiple factors. Most importantly is avoidance of medical care, because the patient having this fear of getting the virus in the hospital. So they are avoiding coming to the ER, which is, of course, is very bad. And then redistribution of healthcare resources. So maybe patient coming to the ER, but people are busy with other COVID-19 related cases that's overwhelming the emergency, and those patients don't really get the care they normally get. So you see here, this is data from California. And as you can see, with the pandemic, you see this is the line for acute MI in 2020. And you see with the pandemic, you see a decline in the number of acute MI as compared to 2019. You see the same thing. This is from England. And again, it's the same thing. You see the decline in non-STEMI is more than STEMI. And that's probably because STEMI patients would have more symptoms and they are more likely to present to the ER as compared to non-STEMI, which maybe patients' symptoms not that much, so they stay at home. This is the same information from Italy. You see this is a reduction in all MI, about 48.4%, but the reduction in non-STEMI is 65%. Reduction in STEMI is 26.5%. What about the outcome? You see the outcome of MI in 2020 is much worse than in 2019. You see the difference of outcome in mostly STEMI patients, 4 versus 13.7%. You see increase in the mortality with non-STEMI as well, although this is not statistically significant. So it's mostly the STEMI that's affected. So let's now move to the next topic, which is management of coronary artery disease, in the COVID era. So we have to take into consideration multiple things. First of all is safety of patients. So we really shouldn't avoid or delay taking patients who really need procedure. If patient needs to go to the cath lab, we should take them. At the same time, we need to minimize potential exposures. So for example, patient with stable coronary artery disease, maybe they don't need to come to the hospital and go to the cath lab. Maybe they can be treated medically until the pandemic is over. We also have to take consideration safety of healthcare workers. We have to provide PPEs and minimize exposure to our team, and judicious utilization of resources. So we have limited PPEs. This is why initially in the pandemic, we decided to go down and limit the number of cases we are doing. We continue to do emergency cases, but for a while, we stopped doing routine cases. And this is also part of prioritization. We have limited bed capacity and staff availability, and we have to be careful about where to put our resources during the pandemic. Prioritization is important. This is European guidelines, and basically they are talking about how we can prioritize patients. So if you have emergency, they need to go to the cath lab without delay, like STEMI, high risk non-STEMI, cardiogenic shock, and so on. Then in the other side, you have the electives that can wait more than 3 months, and you have anything in between. Now, those patients under urgent to be performed within days, I would advocate that we do those cases as soon as possible. And the idea is that you don't want to keep your patients for a long time in the hospital. Those are patients who are hospitalized. The best thing to do during the pandemic is cath them and send them home as soon as possible. Otherwise, they will stay in the hospital. They have risk of getting the infection or transmitting the infection to either other patients or to the staff. STEMI in COVID-19, this is the published data so far. We have more frequent in-hospital presentation. We have more thrombotic lesions and pathologic reports of microthrombi, more frequent no culprit lesion, ranging from 5 to 55%. and higher mortality ranging from 12 to 72%, and considerable controversy about what to do about those patients. However, we have some guidelines. So this is the American SKY guidelines. And as you can see, if you have a patient with ST elevation and COVID positive, they advocate to confirm that by using point of care ultrasound to confirm the regional wall motion abnormalities, and then take them for primary BCI if those are patients with actually 2 STEMI. The problem during the pandemic, those patients, they have ST elevation, but they don't have coronary artery disease. So they could be having myocarditis or something else. This is why the point of care ultrasound, if this is not clear, you can always go for a proper echocardiogram. Now, if you have a possible COVID-19, so every STEMI case should be treated as possible COVID. And again, if those are confirmed or clear as STEMI, then you take them for primary BCI and take care of their STEMI. So all STEMI patients should be managed as COVID-19 positive, as we said. This is European guidelines. Primary BCI is first-line therapy if it can be performed in a timely fashion, meaning 120 minutes from time of diagnosis, not the symptoms. This is basically I copy-paste from the guideline, and because the guideline is written like in hurry, so you see those little mistakes that normally you don't see them in the guidelines written at time other than this time. So fibrinolysis, if not contraindicated, can be considered only if there is a delay, and complete revascularization to be considered so that you don't bring patient back to the cath lab for staged procedure. However, I have to warn you if, because you don't want to keep those patients too long in the cath lab. So unless really very tight lesion, otherwise maybe staging them, sending them home and bringing them after they are not having COVID, maybe is a better idea actually. And they also advocate for doing left ventricular angiogram instead of echo to evaluate for LV function. This is the management.
Dr. Khalid, the time is over. How many slides you have?
I wanted to talk about NACME, but I can't skip that, no problem. If you give me 2 minutes, can I take 2 more minutes?
Yeah, sorry.
Okay. Okay, very nice. So this is the European guidelines, and basically it's the same thing. So the difference here with non-STEMI is if you have very high risk patient, you treat them like STEMI, take them to the cath lab. If you have the same thing with high risk patients. If you have intermediate risk or low risk patient, then maybe you do non-invasive testing to prioritize them, and maybe CT scan or stress test, and maybe take them to the cath lab selectively. Again, this is very high risk patient, treat them like STEMI. High risk non-ST elevation ACS should be tested before going to the cath lab, and CTA if feasible. Anyway, so this is the initial outcomes from NACME, which is the North American STEMI registry. This is collaboration from different institutions in the US and Canada. And you see here more prevalence of diabetic patients. This is the COVID positive. This is the confirmed COVID group. This is the patient under investigation. They don't have COVID, but when they came with their STEMI, they were suspected to have COVID. Later on, they were negative. And this is the last group, propensity matched group. This is from historical database. So as you can see, there is more African American, more Hispanic, more diabetic in the COVID time. Lower EF, more cardiogenic shock, more infiltrates, more dyspnea, more in-hospital presentation. This is all expected, as we said, during COVID. And as you can see, thrombolysis is really not that much different because those patients are actually going to the cath lab. And you see here the door-to-balloon time for COVID patients at 80 minutes, non-patient under investigation 78 minutes, even better than the time before COVID. So those hospitals did really very, very well managing their patient. No angiography is more common as compared to the time before the pandemic. And this is because you have a lot of patients who have STEMI for other reasons other than actually through MI, maybe it's myocarditis or something else. You see here the outcome. This is the last slide. So the outcome for COVID-19 positive patients is much worse than the historical match or patients who are just under investigation. And take-home messages. So elevation of cardiac biomarkers in COVID-19 patients are common and indicate worse prognosis. Causes are usually non-coronary, non-ischemic myocardial injury, type 2 MI or combination of both. The pandemic had negative impact on CAD patients, as we have seen, and management of CAD should take into consideration multiple things, including risk-benefit ratio to the patients, safety of healthcare workers, and prioritization of healthcare resources. Primary BCI during the pandemic is feasible, as we have seen. Door-to-balloon time can be achieved easily, even with the precautions that we are taking, and this should be the default strategy. Thank you very much. Sorry for the delay.
Thank you so much, Dr. Khalid Saidi. Now the stage is open for questions. If you have any question, you can raise your hand, or there is a button called Q&A. You can write your question there. Meanwhile, Dr. Ahmed Rida, can you share your screen? Okay, we have one question.
Yes.
Yes, go ahead. Okay, one person raised his hand. We are waiting for his question.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me?
Yes, Dr. Khalid. Dr. Khalid is a pediatric consultant. He's a consultant pediatric cardiologist in Cardiac Cath Lab in National Health Center. Please go ahead, Dr. Khalid.
I would like to thank everybody who asked me to present today. I'll present about percutaneous pulmonary valve implantation. I'll give an update about this topic. Slightly, I hope it will be an interesting and motivating topic for future of this particular topic. So, can you hear me well?
Yes, Dr. Khalid, go ahead.
So, as a lot of our Cath Lab team knows that we are currently using Melody valve and Edwards Sapien valve for our BPVI. Future is changing, and there are other valves coming into the market, like, for example, Venus B valve and Pulsata valve. There's also the Harmony valve from Medtronic, and there's the Altera adaptive pre-stent. In this presentation, I'll just shed a light about those valves and try to expand about the utilization of those valves in different patients. So, as all of you know, that the congenital heart disease with RVOT obstruction are very common, especially tetralogy of Fallot, which we have one patient in every 2,500 live births. In Oman, we have around 89,000 live births per year. So we have around 35 patients per year who will be diagnosed with tetralogy of Fallot. There are other patients with pulmonary valve stenosis, pulmonary atresia. Those patients will require usually a relief of the RVOT obstruction, either by valvoplasty or sometimes either by cath or surgical, and sometimes transannular patch, especially in tetralogy of Fallot. And this usually leads to a long-term sequelae because of the incision on the RVOT, which leads eventually to RV dilatation, dysfunction, arrhythmia, exercise intolerance, and right heart failure. And eventually there is a risk of sudden death. Surgical pulmonary valve is well known and time-tested and well-tolerated operation with acceptable morbidity and mortality. We are anticipating a huge number of patients will be graduating every year who will require BPVI. Unfortunately, those patients will require different type of valves because of their different anatomy. So briefly, transcatheter pulmonary valve replacement started and was firstly described by Banhover in 2000. And for the last 20 years, a lot of development happened in this field. Banhover started implantation of a valve in RV to be a conduit, which usually a cylindrical shaped conduit, which usually a very classical and typical indication for a melody valve. Okay. This is a historical timeline for the development of transcatheter pulmonary valve. The first implantation was in 2000, and then the first use of melody valve was started in England in 2003. By 2005, there was around 100 patients had implantation of the melody valve. This eventually developed and leading to the first utilization of Sapien XT valve in 2016. All of those, the first two valves were balloon expandable valve. Unfortunately, those valves are not meant for native RVOT, because native RVOT, they have interpatient variability. So as you can see in this diagram, the RVOT has a variable structure with the different shapes of the RVOT, and the variability of the shape starts from the RVOT itself, the annulus, the residual annulus, the patch that the surgeon usually use for the reconstruction of the transannular patch, and the different types of the different stenosis usually at the left and right pulmonary arteries. There is also another variability, which is the dynamic variability of the RVOT during the cardiac cycle. There is also the irregular shape and the large size and unpredictable compliance in those patients. A lot of development to characterize the RVOT before implantation of the valves. 3D rotational angiography have been utilized to assess the RVOT and to assess also the coronary compression. Unfortunately, so as you can see in this video, you can see the balloon test of the RVOT, and you can see the coronaries looking for the coronary compression. This is another 3D rotational angiography showing the coronaries away from the RVOT, and you can see there is a waste there at the annulus of the previous valve. This is a very helpful technology to look at the both the coronaries and to look at also at the different type and shape of the RVOT, and to plan ahead for which type of valve will be suitable for that RVOT. Moving forward, so I will not speak about the Melody valve, neither about the Edward valve. Melody valve and Edward valve has been utilized in our center we have a good experience about them. But looking into the future, I think we should start thinking about self-expanding valve. One of the best option in this field is the venous B valve, which has been produced by Venus Medtech company in China. The first clinical trial started in May 2016, and the primary outcome was published recently in the Eurointervention. And currently there is a pre-marketing study in the Europe and also USA and North America also. So what is this venous B valve? It's a nitinol support. So this is a self-expanding valve, has two spikes at two ends. It is covered fully with a porcine pericardium tissue. The pulmonary end is not covered, and usually it hooks in both pulmonary artery and gives stability, and this usually hooks into the RVOT. The entirety of this area is covered with the porcine pericardium. There is a flaring at both ends. The flare at the pulmonary end is around 10 millimeter. The flare at the RVOT end is around 7 millimeter. This gives stability to the valve, and it, especially in native RVOT, it prevents paravalvular leak, and it prevents also the embolization of the valve. These stents come into different diameters ranging from 16 to 32 millimeter, and usually the increment will be around 2 by each valve, and there are different length for each valve. Here you can see the different stakes in implantation. We start with angiography. After that, looking for any coronary compression. The good thing about this valve, you don't need a pre-stenting, so you go directly with the valve. You go slowly, the valve will open by itself. Usually we start deploying the valve at the entrance of the left pulmonary artery. After opening the valve, still it will be hooked down in the delivery sheath. Once the position is confirmed, that hook will be deployed. Here you can see the valve is functioning well. In this study, which was, they looked at around 55 patients. All of them has been operated late, because this has been done in China, and most of the patients with radiovalve will be operated late. So all of them has been operated at around 13.1 median 13.1 year, with a weight of around 53 kg, plus or minus 9 kg. All of them, they had a normal ejection fraction. Their RV in diastolic volume index was around 139. And there was, as you can see, most of the valve that has been implanted, usually a larger size valve, which is around 30, 32, 32, 30. And probably those will be around half of the patient for native RVOT. Those patients usually are not covered by the balloon expandable valve. And till now, in our institution, those patients will be going for surgery for implantation of the valve. Looking at the result of this valve, so this is prior to implantation. All of them, they had a moderate to severe pulmonary regurgitation. After the implantation of the valve, almost all of them, they had trivial to mild pulmonary valve regurgitation. On the long term, the 12-month follow-up, nobody had an RVOT stenosis. So the gradient maximum was around 20 millimeter. And there was an improvement in the symptoms of the patient. MRI showed improvement in the RV in diastolic volume, coming down by around 40 ml per meter square. So it was really a promising result from this study at around 4 Chinese centers, and we are looking ahead for the result for a pre-marketing study for this type of valve. The good thing about this valve, there is no pre-stenting is not required. It's easily positioned because of the design, and there is a success rate. During this study, it was around 98%. The only relative contraindication is what we call it a reverse inverted cone shape RVOT, where you will have a very narrowed distal MBA with a narrowed LBA and RBA at origin. So in those instances, there's a high risk of embolization. And you can see this valve here embolized. And I think this is the only valve in this study that has embolized to the RVOT. In the 12-month follow-up, 2 patients died, 4 had infective endocarditis, no stent fracture. And so they didn't really comment about what happened to those patients and why they died. Those patients who had infected, the risk of infective endocarditis is high. It's a count around 8% of the patient that had the valve. And this was attributed actually because they said it's in the Chinese group, both surgical and percutaneous valve have a high risk of infective endocarditis. And this is might be because of non-adherence to infective endocarditis prophylaxis. Here too, valve that has been implanted. You can see the valve at the RVOT, and there is a waist there. It's a previous ASC device, and usually our wire will be in the left pulmonary. The valve is expanding slowly. There is no hemodynamic instability during the development of the valve. The second valve is the pulsata valve. It's also a self-expanding valve. It is a Korean valve. They published their first result recently in 2018, and we are still waiting for also the pre-marketing study. They implanted around 10 valves with a great success, no embolization, no history of infective endocarditis, but it's a very small size. They only implanted 10 cases, which shows improvement in the NYHA class, and also in the volumes of the RV in diastolic dimension. So we are looking ahead for future for this valve. I think there are trials currently in Turkey, and also Europe, looking at the feasibility and success of this valve. Moving ahead, so this valve we have been waiting for a long time for this valve. Unfortunately, there was no it was not really that successful. So Medtronic, they had their Harmony transcatheter valve. It was the first self-expanding valve. They started implanting the first one in Great Ormond Street, and this was by 2010 by Philip Bonhoeffer. They used porcine pericardium, and they mounted it in a cavernitinoid self-expanding valve. It's unfortunately still not yet designed for marketing. They have only one size for this valve. The length is around 55 millimeter. It's asymmetrical design, and they use it for very large native RVOT, which reaching up to 34. They recently published their initial result on this valve. So they recruited 52 patients. From those 52 patients, they implanted only in 21 patients. So they are really rigorously selecting the patient in which they are implanting this valve. And usually they select the patient by doing a 3D reconstruction of the CT angiography for those patients. And sometimes they do also 3D printing of the RVOT and try to test it with Cath Lab if it is successful or not. So they had also a good result with this valve, where and there was still there is a risk of fracture of stent with this valve. There is a good result, and we are waiting and anticipating this valve. Thank you very much. This is a short presentation. I highlighted the most advanced and awaiting pulmonary percutaneous pulmonary valves that we are anticipating and waiting for, especially the pulmonary venous valve. Thank you very much. I can't hear.
Okay, thank you, Dr. Khalid, for your great presentation. The stage is now open for questions. Dr. Ahmed Rida, can you start screen sharing meanwhile? Okay, for all the audience, you can raise your hand on the lower side. There's a raise hand, and you also can type your question in the Q&A. There is a link button down called Q&A. If you can write your question there or raise your hand. Okay, Dr. Khalid, there is one question for you. Oh, no, that's a thank you.
Later.
Okay, thank you so much, Dr. Khalid, for your great presentation. We'll move on now with Dr. Ahmed Rida. He's an internal medicine specialist. He's a cardiology subspecialist and interventional fellowship consultant. He's working now as a consultant in National Health Center, Royal Hospital in Oman. Dr. Ahmed, you ready?
Hi. Good afternoon.
You can start.
Can you hear me?
Yes, your voice is clear. If you can start.
Very good.
Slideshow.
Okay. Hi, colleagues. Good afternoon, everybody. I'm glad that I'm here, but I apologize because of some technical problems. And no, because we don't have enough time, I will start about the spontaneous coronary artery dissection scan. The predominant mechanism of the SCAT is two mechanisms. One is formation of the intramural and tramural hematoma, and second, intimal disruption. Epidemiology, up to 1% to 4% of the ACS cases overall occur mostly in women, and up to 35% of the MI in women less than 50 years old are from the SCAT. Also, up to 43 pregnancy-associated MI is from the age, the average age of the women with SCAD is ranging from the 45 to 50 years old, but from 2nd to 8th decades of life. Men with SCAD are younger than women with SCAD, and the mean age for the men is 48.6, and for the women is 52. What is the condition and risk factor for the SCAD? The most associated condition and factor for the SCAD is fibromuscular dysplasia, that is about 25% of condition and risk factor. After that, pregnancy, multiplicity, some connective tissue disease, exogenous hormones, and systemic inflammatory diseases. But the most important is the muscular dysplasia. What is the precipitating factors that can induce SCAD for the patients that have the factor? First, intensive exercise, intensive Valsalva maneuver, intensive emotional, exactly for the women, and lifting heavy objects, vomiting, coughing, labor and delivery, use of cocaine, methamphetamine, exogenous hormones, clomiphene, beta-hydroxysteroid, and also proton injection. From the anatomic side, the most common site for the SCAD is LAD. After that, LCX, after that, RCA, and less left main. And in the majority of the cases, mid to distal part of the arteries are more affected. From the histopathological classification, the spontaneous formation of the intramural hematoma is in the wall of the coronary artery. But there is two theories for the SCAD. As you know that in the routine dissection, we have a spontaneous, we have event in the vessel wall, but in the SCAD, maybe we have a spontaneous hemorrhage from the vasovasorum. Vasovasorum arteries are very small arteries that nourish wall of the vessels, and may they perforated or disrupted, maybe we have intramural hematoma. But the problem is that what is the main mechanism? We don't know. And if at first it initiated in the intramural hematoma, and because of the pressure, we will have intimal rupture, or at first we have intimal rupture, after that we have intramural hematoma. As you see, in the A, it is a normal artery, the lumen, intima, media, and adventitia. In picture B, you can see intramural hematoma without any rupture in the intima. But this tear, the intimal tear is the primary problem. After that, we have intramural hematoma or not. At first, we have intramural hematoma. After that, we have intimal tear. Is not clear in the SCAD. In SCAD, association of SCAD with the multifocal FMD in extracoronary artery is the most commonly reported. FMD, what is the FMD? FMD is a non-atherosclerotic, non-inflammatory that can affect nearly any arterial and can be manifest as arterial stenosis, aneurysm, tortuosity, and dissection. In multifocal FMD, we have alternating stenosis and dilatation. that we say that a string of beats. But in the focal FMD, we have only single concentric or tubular narrowing. In this picture, you can see multifocal FMD, as we said that the string of beats, you can see in the renal artery, that is the most common in the renal artery, and after that in the carotid arteries. Pregnancy-associated SCAD is a small proportion of the SCAD, but the most common cause of the MI in the pregnant or postpartum patients is SCAD, not atherosclerosis. The prevalence of SCAD in pregnancy is 1.8 in 100,000 pregnancies, and most common time is third trimester or early postpartum, but it can be from the 5 weeks of the gestation up to 1 year after delivery, and particularly in women that are still lactating, maybe after 1 year we have a scan. Most common site is LAD and left main, but in the normal SCAD, you see that left main is a less common site, but in this SCAD at pregnancy, left main and LAD is the most common site. It is supposed that some change in the estrogen and progesterone during pregnancy may be cause of the SCAD and his age of pregnancy. And what is the comorbid condition with pregnancy-associated SCAD? The patient that are multiparity, that in the black race, that patient has chronic hypertension, lipid abnormality, chronic depression, migraines, advanced maternal age, age at first childbirth, treatment for infertility, gestational hypertension, and preeclampsia are comorbid conditions that can induce SCAD in the pregnant patient. The average age, as said, it is 33 to 36, but if the patient first time pregnancy it be older, in older age, it is most common. In pregnancy-associated SCAD, the patient are very poor prognosis than patients are related to pregnancy, because in pregnancy we have larger infarcts, more proximal arteries dissection. That is in the pregnancy, 86% of the patient are in the proximal part of the artery as dissected versus 90% in the non-pregnant patient. The patient with pregnancy-associated SCAD are younger and with more ST elevation MI, more left main, or more multivessel dissection. LV function is poorer and less likely to have concurrent FMD, despite of the non-pregnant patient that we said that association with the FMD is much, but in pregnant patient, concurrent FMD is less likely. But you must know that SCAD does not seem to be strongly familial. And the most commonly reported precipitant factor in men is physical extreme activity, and women emotional stress. Very important. What is the sign of the SCAD? The most common sign and symptom of the SCAD is like a usual ACS and MI, which is chest pain, and the other symptoms are like the normal MI. So with symptoms, we cannot understand it is SCAD or a normal MI. We have 3 types of angiographic classification of the SCAD. Type 1 is like routine dissection that we see as multiple radiolucent lumens or arterial wall contrast staining. That is very important that you must know type 1 is only near 30% of the patient with SCAD. But type 2 and type 3 that are diffuse stenosis or focal stenosis are the most common angiographic classification. So if you use radiolucent lumen like other dissection, you will lose 70% of the patient with SCAD. And in this picture, you can see type 1, that is a routine dissection that we can see in the routine dissection of the coronary artery multi-radiolucent lumen. But type 2, you see that long diffuse and smooth narrowing, and type C is focal tubular stenosis. Type 2 and type 3 totally is 70%. So it is very important to know that sometimes you see only a spasm or something like a spasm, and you see that it is a spasm. But you must know that you must inject intracoronary and rule out a spasm. Maybe it is not a spasm, and it is a dissection, an intramural hematoma that looks like a spasm. As you see in this picture also, it is type 1, a radiolucent lumen, but type 2, you see, and type 3, you see that focal, like a focal spasm, that is not a spasm, it is intramural hematoma, and here in B, you see diffuse, something like a spasm, but it's not a spasm. Also, is type 2, type 3. Okay, from the diagnosis, the first line diagnostic imaging is angiography. Catheter angiography is the first line diagnostic imaging method. But we know that the problem of the angiography is that it is a two-dimensional luminography, and we cannot see anterior wall, arterial wall. But the most important is that you must know that if you want to diagnose the SCAD, you must send the patient for the angiography. But we know that the angiography has some problems in the SCAD, but if somebody that is doing angiography be aware of the SCAD diagnosis, the rate of the complication will be less. Another diagnostic tool is IBUS, that you can use IBUS for the diagnosis, but another tool is OCT, but we don't use OCT and IBUS routinely because of this problem that the IBUS and OCT both can extend the coronary dissection by wire or the imaging catheter. We can have guide catheter iatrogenic dissection. We can have catheter-induced occlusion of the true lumen or hydraulic extension with contrast injection, especially in the OCT that you know that you must inject contrast continuously to have a good image. So the best option is angiography. Okay. About the coronary CT angiography is not a good diagnostic tool and is only used when you want to follow up the patient with the SCAD, but for the diagnosis of the SCAD, it's not a good tool. It's better that don't use the CT angiography for the diagnosis of the SCAD, because if the CT angio be normal, you cannot exclude SCAD. Okay. It is the coronary angiography after intracoronary nitrate. You can see type 1, type 2, and type 3. But if you are uncertain about the diagnosis, you can use OCT, IVUS, CT angiography, CT MRI, etc. But none of them is superior than coronary angiography. And is coronary CT angiography, we have a problem that is useful, but for the proximal and large caliber coronary artery, the SCAT, if is involved distal coronary artery, or side brancher, or vessel caliber less than 2.5 mm. Generally, coronary CT angiography is not a good candidate for the diagnosis. Okay, because in the SCAT, we said that it is a very co-prevalence of the FMD in the extracoronary vascular and abnormality. When you have a SCAT, you must have vascular imaging from the brain to pelvis. In all patients, you must search for the FMD in the intracranial, extracranial, and also in the renal arteries to rule out the FMD. Management of the patient. The best management of the SCAT is medical treatment. And the interventional treatment is not a good treatment for the SCAT. In 70 to 97% of the patient, after weeks to months after conservative treatment, we have the healing of the SCAT, and it is the best option for the patient. And for the patient that are clinically stable without objective evidence of the ongoing ischemia, or in the patient we have occluded distal vessel or distal branches that could not routinely be amenable to PCI, it is better to use conservative treatment. But you must know that recurrent MI in 5 to 10% of the conservatively managed patient, in first 7 days of the admission we have. So it is better the patient with the SCAT be admitted at least 7 days in the hospital. After that, you can discharge the patient. But the problem is that the majority of the patients that are managed conservatively, but they have recurrent MI, maybe require emergency revascularization. But no angiography or clinical predictor of acute worsening has been identified. So conservative treatment is a good candidate, but not a good treatment in the high-risk patient. Which one? High risk, the patient with ongoing ischemia, left main dissection, and hemodynamic instability. In this situation, you must use PCI or CABG for the patient. But PCI is not a good treatment for the SCAT intervention, and the best option for the patient is CABG. Okay. Because in the PCI, maybe you pass the guide by to a false domain, maybe you use balloon dilatation, and the balloon dilatation can propagate intramural hematoma and dissection anterogradely and retrogradely, and extend it toward proximal part and distal part of the cell. And also in complete PCI may require line coronary stent that can induce stent stenosis and stent thrombosis. And also if the SCAT has affected distal part, we cannot use PCI for the distal part. And another problem is that when you have intramural hematoma, after sometimes it will resorb And after that, if you put a stent, you have malopposition and predisposing to the future risk of the stent thrombosis. So if you have to send the patient for the PCI, you must know that you must avoid of the deep catheter engagement, non-coaxial position of the catheter, and catheter damping, and also you must avoid all the strong contrast agent injection. What is the best access? The best access is the femoral access, because they have seen that in the radial access, iatrogenic dissection in radial is threefold of the femoral access. So the best option for the SCAT is femoral, not radial. Okay. And when you want to put a stent or treatment with the PCI, we have some options. One option is that you must use 5 to 10 millimeter on both proximal and distal part longer stent, because you know that in the normal, when we want to put in the stent, we use only 2 millimeter in the proximal or distal part of the lesion. But in the SCAT, you must use 5 to 10 millimeter proximal part and 5 to 10 millimeter distally. And so in this situation, you need a long stent. That is not a good option.
Dr. Ahmed, 2 minutes.
Okay, thanks a lot. And also, we can use in the PCI direct stenting without balloon, or we can use only some author says that it's better to use only ballooning or POBA without the stenting. And sometimes they say that you can use cutting balloon because of we have intramural hematoma. With cutting balloon, we can penetrate the intima and we can decrease intramural hematoma. It is a theoretical. And another option for the stenting of the patient with the SCAT is multi-stent approach. That is, you can use one stent for the proximal part, one stent for the distal part, and between these two stents, after that, you can put the stent, because it is proximal and distal part stent can inhibit intramural hematoma propagation to the proximal and distal part. But another option is that the use of the bioresorbable stent, that after resolving of the intramural hematoma, it can be resolved also, and we don't have any more opposition. But you must know that best option, we said that is medical treatment. After that, if we want to put intervention, the best option is ABG. Exactly in the left main system, proximal dissection, technical failure of the attempted PCI, and complication of the patient with the PCI, and the refractory ischemia despite conservative treatment. Okay. We have many pictures, but I think it is enough. But if there is any question, I will be happy to answer the question. But it is a presentation I will give to my colleagues in the Cath Lab. If anyone needs a complete presentation, can use it, because it's 140 pictures that at with this time I cannot explain all of them. Any question?
Thank you so much, Dr. Ahmed Raza, for this great and informative presentation. If there is any question, kindly write your question or raise your hand. Meanwhile, Sister Leila, can you share your screen? Is there any question from the audience? Raise your hand, please. By the way, in Q&A, down that button in the lower side of this Zoom, You can type the question anytime in the presentation. We can see it at the end of the presentation. So it seems there's no question. So Sister Leila, are you ready? Thank you, Dr. Ahmed Rida, for this presentation. Thank you so much.
Thanks a lot. Thanks a lot. Have a good day.
All the best. All the best.
Allah. Assalamu alaikum again. I'm sorry for the technical problem. Now I will share with you my presentation. So I'm going to present about the efficacy of intravenous hydration in prevention of contrast-associated nephropathy. Previously, in National Heart Center, I had presented, and it was the efficacy of intravenous hydration in prevention of contrast-induced nephropathy. But after reading more about this topic, I had to change it because due to the new research and new paper published in this topic, they are changing the phenomena from induced nephropathy to associated nephropathy because this issue actually raised with the patient whose renal function already compromised. So it is associated with the nephropathy and it will exacerbate the problem. So in this presentation, first I'm going to give a brief introduction about the contrast-associated nephropathy, epidemiology, its definition, but pathophysiology, risk factor, and what is the assessment, treatment, and prevention, and some of the published research on this issue. So contrast-associated nephropathy, it is a common and complication of all procedure use the contrast on it, and on coronary angiography, it is continuing every day with all as a complication, and it is considered as a third leading cause of acute kidney injury in hospitalized patients. And it is because it is asymptomatic, it is not easy to recognize it unless there is pre-investigations and identifying the risk factor of this patient who is at risk to develop it. And so for that, the best treatment of contrast-associated nephropathy is prevention. And this epidemiology, according to the research being published, 15% of patients undergoing radio contrast procedure may develop contrast-associated nephropathy, and 1% of all patients develop contrast-induced associated nephropathy. 1% of them, they may require dialysis after this acute problem. And from those who is going for the dialysis, 30 of them, there will be risk for long hospital and the complication of mortality. And 80% also, they will be at risk of dying within 2 months. So it is important to look at it, since it increases hospital length stay and increase the cost, and more important because it is increased mortality and morbidity of the patient who is coming for angiography. So what is the mean of contrast-associated nephropathy? Many research and many books has defined it as it is increase of serum creatinine 0.5 milligram per deciliter or greater than 48 hours of contrast use, within 48 hours of contrast use, or 25% greater in baseline serum creatinine within from 5 to 7 days. And also, and these rays actually will come or will be noticed 24 to 48 hours after contrast administration, but this problem will be lasting 1 to 3 weeks even with the treatment of hydration or other medication. But there is new research being published by Mihran 2019. It is they changed the criteria or the definition by as they define it as increase in serum creatinine 0.3 milligram per deciliter or greater more than 0.3 within 48 hours of contrast use, or increase in serum creatinine 1.5 to 2 times from baseline of the patient, or it is urine output decrease 0.5 ml per kg per hour for more than 6 hours. So they recognize it and they defined it according to many research being done. And this study being published only last year in Berlin. Going through many research, there is no clear reason about the causes of contrast-associated nephropathy, but mainly they discussed about nephrotoxicity and disturbance in renal blood flow. The patient is having the risk factor to develop the nephropathy by giving or exposing the patient to contrast. So patient will have association or will develop the nephropathy. So how we can prevent this issue from patient going for angioplasty? First, by determining risk of acute kidney injury. And this only can be done by identifying the risk factor on patients. So all patients coming to the Cath lab or going for procedure must be identified if they are at risk. So they classify the risk intrinsic and extrinsic. Intrinsic, which is related to the renal failure or patient who is having hypotension, presence of congestive heart failure, with more, it will be with all elder age, and anemic patient, diabetic, and the use of other nephrotic drug, which will decrease the glomerular filtration rate of the kidney. And as extrinsic risk factor, we have the type of contrast used in the procedure. If it is hypotonic, it will, or hypertonic, it will be more risk to develop the nephropathy, and also the time period between two contrast media exposure. So if patient is not given the good enough period for the kidney to get rid of that contrast and being exposed again to another amount of contrast. So here we are keeping the patient at risk, or patient will be at risk to develop the nephropathy. For that, there were many risk assessment score being developed, and here I'm presenting Mihran, which is considered a strong risk assessment and being utilized in many hospitals. So he categorized the risk factor into 4 categories, and this category is depending on risk factor. So if patient is having, here we can see, if patient is having more than 5 points of all this risk factor, which is decreased renal perfusion, or older age, anemia, diabetes, contrast media volume, that's mean about how much being given to the patient according to the body weight, and impaired baseline operation having impairment in his renal function, and that one we are calculating about with the GFR of the patient. So all being categorized with some, he has defined each of these criteria or risk factor, and he put score for each of them and categorize. First patient will be low risk if having or no risk if having less than 5 points. So patient will be only 7.5% at risk to develop it, or 0.04 to go for dialysis. Category 2, if patient is having 6 to 10 points from that risk score, so patient will be at risk 14% to develop the nephropathy and 0.12% to go for dialysis. And category 3, it is having patient 11 to 16 points with all of this risk, so patient will be at risk to develop the nephropathy 26.1% and to go for dialysis 1.09%. Category 4 is if patient is having more than 16 points from all of these risk factors, and the patient will be 57.3% to develop the nephropathy and 12.6% to go for dialysis. And this is considered very high score category of patient having all these score. So in order to prevent the nephropathy or contrast associated nephropathy, after determining whether risk patient or patient who is at risk to develop this issue, so here we have to give more care than other. Though we have to consider all patients, but these patients, because they are having the precipitating factor to develop the this issue or this problem, so we have to make sure to use low osmolarity contrast media, though it is and minimize the contrast volume. And there is many research on this which showed that adjustment of contrast with the glomerular filtration rate allow reduction of incidence of contrast associated nephropathy. And though we are reducing the amount which is used or selecting the appropriate media of the contrast, still the scenario inside the cath lab, it cannot be predictable, because nowadays most of the cases will take a long time, as we have CTO cases, or we having some complex procedures. So here we have the other way to prevent the problem to be developed in cardiology patient or patient going for coronary procedures. So we have to administer intravenous isotonic sodium chloride, and this administration should be monitored or controlled. And here we are, according to studies being published and what's been followed in our hospitals, that the rate of 1 to 1.5 ml per kg per hour during the 12 hours before and post procedure if patient is coming electively. And in primary procedures or rescue procedures, the patient will be, the fluid infusion will be 3 ml per kg in all the primary procedures. And there is a study by Boisini, which is said that during emergency procedure or primary procedure, we can utilize the LVADB to guide hydration, the amount of hydration to the patient to get the appropriate amount to hydrate the patient to avoid this nephropathy. So LVADB is important, and I will show how they calculate it and what the studies been issued, what the detail of LVADB. And the hydration, but the hydration, we have to take in consideration also the hydration to maintain the intake output, because here we don't want also to create another problem or overload for the kidney or for the heart and exaggerate the problem, treating one problem and raising another issue. So here we have to monitor the for our patient. We have to monitor intake and output, and maintain the sufficient intravascular volume of renal perfusion. So here, if our patient is having dehydrating and going to the contrast media, here will increase the risk of the nephropathy. So we have, and also if we are hypervolemic or giving patient much fluid, here also the kidney will be overloaded, and renal perfusion is already pressurized. So here, and we're introducing the contrast to the kidney. So here also we are troubling the kidney, or allowing the problem to happen. So balanced hydration and avoiding dehydration, avoiding hypotension, all this will, with the proper hydration, this will help in reducing or avoiding the nephropathy. So in patients with poor systolic function or chronic renal failure, as most research showed that 0.5 ml per kg per hour is the most suitable fluid amount, can be calculated. But if it is, this is can be used in pre-procedure if patient not gone. But if patient is going to the cath lab, so here the doctors himself can decide, or the physician or the interventionist, they can decide the amount needed for each patient, or by personalized dose by using EDB. So after this phenomena being raised and patient treated, we know we cannot stop taking care with fluid after giving fluid, because if patient is at risk to develop the nephropathy, and we given them the prevention by giving appropriate fluid and avoid use of much of contrast, but still we have also to monitor patient post procedure, which we are following in our hospital or center, but it is to confirm it that patient must be followed for his kidney problem, for his creatinine level, GFR, and for urine output, to avoid the complication post procedure. And here some research been published on this topic, and this is a control study, randomized control study, found that prophylaxis to be non-prophylaxis to be inferior to and cost a saving in preventing contrast associated nephropathy compared with hydration. And also, this is the study with Poseidon randomized control trial, which is published 2014, and it showed that hydration has a good impact in reducing the contrast associated nephropathy 59%, and also it reduced 10% of absolute reduction in contrast-induced nephropathy. Another study being issued also that recommended prophylactic intravenous hydration of patients at risk for coronary associated nephropathy, and individual risk must be quantified. And this actually, this study also showing the same, which is personalized dose of hydration will help a lot in reducing the contrast associated nephropathy. And I want to talk more about Poseidon randomized control trial. They showed that if we are taking the LVADB of patient during the procedure, so if LVADB, if it is less than 13, so here the rate we can give patient up to 5 ml per kg per hour, whereas it is less than 18. So patient will be given only minimum dose, which is 1.5 ml per kg per hour. And here we are giving 1.5 ml per kg per hour because it is during the emergency. We can give this much because it is primary, and we need to give to hydrate patient well, and this amount of hydration calculated with LBADB, patient can continue for 8 hours post procedure with this amount of hydration. And this is my topic. If any question, please. And thank you.
Thank you so much, Sister Leila, for the great presentation. The stage is open now for questions. If you have any question, raise your hand or write your question in the Q&A. We received 2 questions already. The first question is not for Leila, for Dr. Ahmed Reza. Dr. Ahmed Reza, are you on board? Meanwhile, the second question is for Sister Leila. Leila, in contrast-induced nephropathy, is it possible to get light renal stones related to the use of contrast after some time?
If patient is having, after sometimes, there is no research the research which I have reviewed, no one of them mentioned about renal stone, unless the patient is having the risk or having the symptom before. Maybe some patient will be denying the symptoms, the patient having the risk to develop any renal problem. But prior to that, patient will be denying. After procedure, exposing to contrast and explaining to them about the patient that he is having at risk of developing nephropathy, they will have more conscious about his renal symptom or renal his renal. So if he will notice any complication or any symptom, he will relate it to the contrast. But I did not read anything related. And other doctors, they can share if they have any another answer.
Dear panelists, do you have any other answer? Okay, I'll move to the second question for now. Is there any difference between the adult and pediatric regarding contrast concentrations?
Yes, because it is depending the contrast. We are using the same contrast for pediatric and adult, which is isotonic, but it is the doses depend on patient weight, which can be given to the patient.
Okay, thank you so much, Leila, for the great presentation. Dr. Ahmed Reza, there is one question for you when you are ready. Okay, Sister Leila, there is another question. What about use of acetylcysteine injection post-procedure for prevention of nephropathy? What do you think about it?
This medication, it is prescribed for patients pre or post procedure, but I did not mention any medication. Here I'm my concentration about hydration with fluid, isotonic fluid, because it is the most safe preventive measurement, and which is also most effective. According to the research being published, it might work, other medication, it might work and might benefit the patient, but nothing is better than the hydration itself. But if we are using it in many patients, they are starting pre-procedures and post-procedure.
Okay, thank you so much for the great presentation. You are lucky having you with us. We'll move now to the last presentation for today with Dr. Mohammed Al-Rashidi. He's a senior specialist pediatric cardiology in National Health Center, Oman. Dr. Mohammed, can you hear us?
Yeah. Assalamu alaikum. Can you hear me?
Yeah, we can hear you.
Okay. Assalamu alaikum. Good evening, everybody. I am going to talk about the utilization of hybrid procedure in the Cath Lab. I'm going to talk about the introduction, first introduction, then examples of hybrid procedure, then conclusion. Actually, the advancement in the surgical and transcatheter techniques has significantly now reduction in the mortality, and long-term survival of these patients now increasing up to 90% than congenital heart disease and 80% in complex congenital heart diseases. However, the mortality is increased, or mortality, I mean reduced, but also the morbidity is increasing. So with more survival, we expect more morbidity. The most common is the neurodevelopmental outcome of these patients, and the need for repeated surgeries, the need for repeated intervention is increasing. So exposure is to cardiopulmonary bypass with deep hypothermic arrest or regional cerebral perfusion is adversely affect the brain of the newborns. So this will increase the neurodevelopmental outcome, the long outcome, especially the intellectual deficit for these patients. So now the surgeon and the internist, they are communicating together. So the surgeon, they want like minimizing the exposure to cardiopulmonary bypass by minimizing the invasive surgical approach. On the other hand, the interventionists, they want to do more aggressive procedures, more devices, especially for newborns now. But they are limited also with low birth weight or low weight of the patients, and the patient may be hemodynamically unstable, and the stiff wires will increase this hemodynamic instability. So now what to do? Now the surgeon and the interventionist, they are communicating together, came with an idea, which is a hybrid, which is called hybrid procedure. Hybrid procedure first described in the hypoplastic left heart syndrome as first stage, and then it expanded very rapidly to involve a lot of procedures. This is the hybrid OT at National Heart Center with the more advanced infrastructure in our center. So I'm going now to do what is this hybrid procedure. In this video, which is shared from another colleague, demonstrating what is the hybrid procedure, how it is done, and this is for the VSD device closure, and it is very ventricular. So now opening the sternum with minimal incision in the sternum or subxiphoid. Then you put a knock in the right ventricle, knock, introduce the sheet, and then go on. The rest of the procedure is the same. But what is the advantage of this is like you can introduce a larger sheet, and also the direction of the sheet and the guide wire will be easy for the VSD or for other procedure like pulmonary valve implantation. Then you close the skin, and it will be like giving you more room to introduce more sheets or larger sheets, stiff wires, and that's it. This is another approach. It is like subxiphoid approach. You have two, either minimal sternotomy scar, you can sternum, or subxiphoid. So subxiphoid is the same. You put an incision. This is introducing the surgeon, introducing this like you giving you a window to introduce your sheet. Then this is how it look after the closure of the skin, and the sheet will be there. So it is initially described in the as a stage 1 of palliation for hypoplastic left heart syndrome. This is I will go then expand it to involve many procedures. I'll give you just a few examples just for this procedure, and the others can be expanded for anything you can think. Hypoplastic left heart syndrome. You know there are two rooms of the heart. Aorta is coming from the left, pulmonary artery coming from the right. In the hypoplastic left heart, the left ventricle is very hypoplastic, aorta is hypoplastic. So the BDA is feeding the distal aorta. So there is no flow to the systemic flow. You don't have. So you need to create a systemic flow. So what you will do? On the other hand, you have here very increased pulmonary flow. So you have increased pulmonary flow and no flow to the distal. So as a first stage variation, you will do what? BDA stent and bilateral pulmonary artery banding. So the surgeon, they are doing opening the chest that time, and they are doing the pulmonary artery banding. At the same time, they can introduce the sheet, and you can do that BDA stent to cover. Currently, we are doing like by the femoral axis with a newborn, low weight, and with all complications. But this high bridge can be done at the same time of the surgery. Then the surgeon can give you the access to the ventricle, or so BDA stent can be done. This is how it looks like the BDA. It's covered from that. This is the angiography of that, and then the stent can be expanded. Same thing, and the down. This is the picture in the downstairs here. Like this is for interarterial septostomy, then stenting of the interarterial septostomy. So you put your cover the stent here and then expand it at the same time. This is also in the left hypoplastic left heart syndrome. Second example, what we can use the periventricular VSD closure, and that video explained what is that. It is the same video here. You can see that the VSD is closed. You open that, giving you an access to the heart. Introduce larger sheet. Put a knock here in the RV. Then control this one. Blood. Then after that, you can introduce a stiff sheet, any larger sheet, or like wires. Then the rest of the thing, it is like the same of the introducing the VSD device, which is with the left side disc, then the right side disc, and so on. So this is like introducing the device. So it's giving you a room for the larger sheet introduction, and this is like the same illustration how you are doing the periventricular VSD closure. Same things. This is like the echo illustration of the same when the guide wiring introducing to the RV, then the sheet, then you put your device here, employed your device, and this is how it looks after that. Same thing. Pulmonary valve implantation. Dr. Khalid, he talked about how it is done, doing it like on different valves. But here the issue that also if you want to introduce it with low weight in a patient with low weight, how you can introduce a larger sheet for this patient, and this high bridge procedure can give you a room of same thing. Introducing this is like a large sheet and large valve, so you can have a room for that. This is like, it's like how it's seen after that, the expansion of the valve. In the pulmonary atresia, also there's another problem. In the pulmonary atresia, if you have an ephemeral axis and this is going into the pulmonary artery is very, very difficult because of the angulation. So you cannot cross to the pulmonary artery to the by this femoral axis or this one. So it's very difficult to cross. So it going to give you a good angulation. By the periventricular approach or something like by high bridge, it gives you a good angulation to that. So a laser ablation of that, the membranous pulmonary atresia, you can perforate it, then can cross, then you implant RBOT stenting so that the growth of the RB will be there and the growth of pulmonary arteries will be there. This is like the periventricular sheet, which is coming from here. Then you introduce your valve there, and it give you an access for larger sheets. So another, like you can expand this is for many procedures. Even it can be now introduced in the ablation for the like electrophysiology, and like they can introduce the sheet here and they can ablate whatever they want, like for if there is an accessory pathways or something. So in conclusion, the high bridge procedure is a promising procedure which can be used as an alternative procedure in patients with low weight or hemodynamically unstable. Thank you. And if you have any question, you are welcome.
Thank you so much, Dr. Mohammed, for the great presentation. Thank you so much, Dr. Mohammed, for the great presentation. The stage is open for questions. There is one question for Dr. Ahmed Rida, if he's alive. Sorry, if he's live. Dr. Ahmed Rida, if you are live, can you answer? Meanwhile, any questions for Dr. Mohammed Rashdi? Okay, there is a question. Oh, sorry, this is not a question. It is not a question. It is a compliment to all for completing the first day of our 7th Cath Lab Day. So proud to be part of this team. Thanks for everybody behind the stage. Thanks for the audience for bearing with us. And we are so sorry for the technical problems that happened, but luckily we are on time. We are, in fact, ahead of time. Okay, it seems that Dr. Ahmed Rida is not with us anymore. And thanks for everybody. Thank you for attending this day. See you tomorrow. Tomorrow we'll start at 6 p.m. 6 sharp. It's not like today. And tomorrow it will be about electrophysiology, pacemakers, electrophysiology, 3D mapping. See you tomorrow. Thank you so much.